Hi, everyone. I'm Frank Evans, a program director in the Heart Development and Structural Diseases branch of the National Heart, Lung, and Blood Institute of the National Institutes of Health. For those of you who may not be familiar, the National Heart, Lung, and Blood Institute is the third largest institute at the NIH, with an annual budget of more than $3 billion and a staff of over 900 employees. As the program director in the Extramural Division of Cardiovascular Sciences at NHLBI, my portfolio includes grants in valvular heart disease, heart failure, congenital heart disease, and magnetic resonance imaging. In 2019, the NHLBI convened a working group on patient-centered research in valvular heart disease at the NIH. The Journal of the American Heart Association published an open access summary of the meeting in its April 24, 2020 issue, meant for researchers, clinicians, policymakers, the general public, and patient interest groups. Today, as part of the Heart Valve Disease Awareness Day virtual conference, I'll be speaking with two NHLBI-supported researchers to discuss the important work they're doing in heart valve disease. First, I'll talk with Dr. Joanna Chikwi, who's a recognized leader in the field of mitral valve repair and coronary revascularization, with expertise in minimally invasive cardiac surgery. Dr. Chikwi serves as chair of the Department of Cardiac Surgery in the Smith Heart Institute at Cedars-Sinai in Los Angeles. Dr. Chikwi is also the editor-in-chief of the Society for Thoracic Surgeons Annals of Thoracic Surgery. Welcome, Dr. Chikwi.
Thank you very much.
I'd like to ask you a few questions regarding your work in mitral valve repair. First, though, for our general audience, could you please explain mitral valve disease and its relationship to heart failure?
Of course. So the mitral valve is one of four valves in the heart, and diseases of the mitral valve are probably the commonest of all of those four heart valves. What we see most frequently in the United States is a valve that is regurgitant, it leaks, rather than a valve that's too tight. And there are two broad reasons for that. It could either be disease of all of the structures around the valve, i.e. the ventricles and the subvalvular apparatus, and that we call functional or secondary mitral regurgitation, or it could be a disease that's primarily due to disorders of the leaflets themselves, and that we call primary mitral regurgitation. And by far the commonest cause of primary mitral regurgitation that we see in cardiovascular practice is degenerative or mitral prolapse. And what causes heart failure is the fact that when you have a leaking mitral valve, every time your heart beats, instead of all of the blood going forward through your aortic valve to the rest of the body, about half is going backwards with every heartbeat. And initially, that happens slowly over time. Your ventricle is able to compensate, but with prolonged time, the ability of the ventricle to compensate fails, and we see patients present in heart failure. So it has been extremely important to identify these patients early in the disease course, because before the onset of symptoms, you can restore normal life expectancy and reduce the risk of heart failure by intervening on the valve to correct regurgitation.
Thank you. You serve as one of two principal investigators on the percutaneous or surgical mitral valve repair, or primary, clinical trial in the NHLBI Cardiothoracic Surgical Trials Network. The study will be evaluating the long-term effectiveness and safety of mitral valve transcatheter edge-to-edge repair, or TEER, T-E-E-R, compared with surgical repair in patients with primary degenerative mitral valve regurgitation. Could you please tell us more about the aims of this study and what you hope to learn?
So this is an exceptionally important study. Essentially, we're comparing two very different approaches to repairing a mitral valve in patients that have degenerative or floppy or mitral valve prolapse. And it's in all patients that are over the age of 65 and don't need other kinds of surgery, such as coronary bypass or aortic valve replacement. This is a potential real game changer. Traditionally, we've always regarded surgical repair as the gold standard. That allows us to carefully tailor a leaflet strategy, usually place an annuloplasty around the valve, and the results in experienced hands are excellent. It's an important factor that you do need experience to repair these valves well. So with experienced teams and experienced surgeons, I would say that a 95 to 99% repair rate is standard. The mortality of this operation is less than 0.5%, depending on the patients that you select. And the long-term outcomes are excellent. I never tell patients this is definitely going to be a lifelong solution, but for the vast majority, for 90-95% of patients, they should not need another intervention for recurrence of their disease. So it's a low risk, highly effective strategy that restores normal life expectancy and in symptomatic patients corrects symptoms. What's emerged over the last decade is a transcatheter approach, i.e. by a puncture in the femoral vein, as opposed to an incision and using the heart-lung machine. You can, in the beating heart, potentially clip the leaflets of the mitral valve together and reduce the regurgitation that way. And early on in the experience, we found that we were able to achieve quite a good reduction in the regurgitation in a reasonable proportion of patients, but certainly not as reliably and consistently and durably as in surgical patients. And that's improved over the last decade, to the point that I think it is very reasonable to say now that in very carefully selected patients, that's in patients that we're selecting based on anatomy, that it's probably possible to effect a good repair of the leaflets using essentially TEER, transcatheter edge-to-edge repair. Now, the reason that there is a question is that we don't know what the long-term outcomes are of TEER in these patients. Patients that we do know have excellent long-term outcomes with surgery. And as a patient, I think that there is clearly a desire to minimize the risks up front of surgery, low as they are. And perhaps in many people's mind is more important, is to try and eliminate surgery altogether. And the question is that compatible with an equally good long-term outcome? This trial is really important. Essentially, for patients that are over the age of 65, we plan to randomize about 450, up to 600 if we need to, because event rates turn out to be lower than predicted, to see if the long-term outcomes of these strategies are equivalent, or if one offers better long-term outcomes than the other.
Thank you. Speaking of surgery, robotic surgery is increasingly used for the treatment of mitral valve disease, and you're at the leading edge. Where are we with the technology today, and where do you think it's headed?
This has been a very important shift surgically. Robotic surgery allows you to, instead of performing a mitral valve repair through an incision in the front of your chest, you're able to relocate that so that you're going between the ribs, usually with under the breast crease or in the side. It's a much, much smaller incision, maybe not much longer than the short end of a credit card. And that allows patients to really oftentimes be out of the hospital within about 3 days as opposed to 4 or 5, but much more importantly, recover that little bit faster without compromising the great long-term outcomes of the standard repair that goes through the middle of the chest. And all that the robot does is allow you to do that more accurately and more consistently. The robot isn't a magic bullet, but it really does facilitate a much less invasive way of doing the surgery. And what I think is incredibly important is that as we evaluate the transcatheter edge-to-edge repair approach, that puncture in the femoral vein, I think that it'll be very important for patients who are not suitable for that approach or would get their best long-term outcomes in terms of best survival and best freedom from recurrence of their disease and surgery, to have that less invasive surgical option, so that the differences in the treatments that we're proposing from a patient standpoint are actually not that great at all.
We know there have been delays in diagnosis and care of chronic conditions such as heart valve disease during the COVID-19 pandemic. What have you seen, and what is your message to patients and clinicians as they continue to work their way through this?
Initially, we saw enormous delays in care, to the point that much needed care wasn't delivered simply because there was huge concern about the safety of doing cardiac surgery while this virus was rampant. And secondly, because of the sheer numbers of people that were admitted to the intensive care units in hospitals requiring ventilation, which essentially precluded running most elective surgical services that required ICU recovery for their patients. And both of those pictures have shifted greatly during the course of this pandemic. Right now, we, like many other centres, are operating back at our normal volumes and our normal level of activity, because our ICUs are no longer quite as full as they were. They're fuller than they normally are, but they aren't quite as full as they were. And the real challenge for us now is that the shift in cardiology practice to virtual and away from in-person has reduced the number of much needed tests, including echocardiograms and cardiac catheterizations, that are needed to diagnose and monitor disease. And that means that patients are still presenting later in their disease course. And it's almost like practicing the way that we did 15, 20 years ago. We've taken this long to understand that early recognition and earlier intervention, usually before symptoms, prolongs life in many of the types of illness that we deal with, particularly in mitral valve disease. And it's almost like we've dialed the clock back to 15 years ago. Patients are coming in with symptoms, with more advanced disease, and while we can still treat them well and safely, their outcomes are certainly compromised by this. So my one message to those physicians listening to this, and to any patients listening to that, is to know that it's safe to go and see your primary care doctor and your cardiologist, and get the imaging that you need to monitor or diagnose disease you may have, and get it treated safely.
Thank you, Dr. Chikwi, for giving us your time today and for the important work you're doing in valve disease.
Thank you very much. It's been a real pleasure.
Our next NHLBI supported researcher is Dr. Judy Hung. Dr. Hung serves as a cardiac radiologist and cardiologist and is the director for echocardiography in the Division of Cardiology at the Massachusetts General Hospital. She's also past president of the American Society of Echocardiography and directs the Echocardiography Core Laboratory in the NHLBI Cardiothoracic Surgical Trials Network. Welcome, Judy.
Thanks, Frank. And I want to thank the Alliance for Aging Research for inviting me to this forum in recognition of AAR's Heart Valve Disease Awareness Day on February 22nd. So as Frank said, I'm a cardiologist at Mass General Hospital in Boston, Massachusetts, and my research interests are in valvular heart disease, and I specialize in echocardiography. Echocardiography is the use of ultrasound to image the heart. And also, full disclosure, I am the past president of the American Society of Echo, which is the professional society promoting quality in echo. So echo is the primary diagnostic tool physicians use to diagnose heart muscle and valve function. It is the go-to method for diagnosing the common valve disorders such as aortic stenosis or mitral valve prolapse. It is safe and can be done simply by using a probe put on the chest wall. And importantly, it is highly accurate, widely available, and cost-effective tool for our patients to diagnose heart disease. Typically, patients can be referred for an echo based on clinical signs and symptoms, such as when patients develop shortness of breath or chest pains, or they can also be referred to an abnormal ECG, chest X-ray, or abnormal finding on physical exam.
Judy, your research focuses on developing techniques for risk stratification in mitral valve prolapse. Why is it important to stratify risk in this disease area?
That's a great question, Frank. And I can't emphasize enough how important it is to risk stratify for heart valve disease. And what this means is to assess how severe the valve disease is and look for certain features of the heart valve disease that puts patients at high risk for poor outcomes, such as heart failure or even death. Echocardiography and the information it can provide plays an important role in helping us determine whether you have heart disease and how severe it is. Additionally, the data from the echo helps the physician decide on recommendations for treatment of heart valve disease, such as type of initiation of medications or even surgical recommendations. I'd like to touch on a particularly poignant example of how much more we also need to learn about risk stratification in heart valve disease. And I refer to the Carroll bill, which is making its way currently through Congress. And this is a bill sponsored by Congressman Andy Barr in honor of his late wife, Carol, who tragically died suddenly from a heart valve condition called mitral valve prolapse. There is no question that we have made significant progress in diagnosis and assessing severity of heart valve disease, but we still have much more to learn, especially about predictors of sudden death. And this bill sponsored by Congressman Barr will be a big help towards these goals.
I asked this of Dr. Chikwi, and I'll ask you the same question. We know there have been delays in diagnosis and care of chronic conditions such as heart valve disease during the COVID-19 pandemic. What have you seen, and what is your message to patients and clinicians as they continue to work their way through?
Sure, Frank, another great question and an important question. I would say that absolutely we saw hesitancy in some patients with chronic heart valve conditions in getting follow-up care, and also for patients with potentially new heart valve conditions for a new referral. And I think this was especially so during the first surge of COVID starting in March of 2020. And understandably, people were afraid to go to the hospital. And the message that I would give patients is that most definitely you need to follow up with care, as delays can result in worse outcomes. You need to take care of yourself. We certainly saw cases where patients delayed getting care, and then they came in a much worse condition than if they had gotten preventive care. So in addition, I feel that we have a much, much better handle on how to keep safe in this pandemic during the initial, since the initial wave, and that patients should feel safe in going into the doctor's office or hospitals to get care.
Judy, thank you for taking the time to talk with us today and share a bit about the critical work that you're doing.
Thanks, Frank. It's always a pleasure.